So Mike will now go in a bit more detail on the COVID project that I very briefly mentioned. And Mike has a kind of joint affiliation between the CMIH and AstraZeneca, but I don't know, Mike, you might say a bit more about yourself. So I'll hand over to you.
Yes, so my name is Mike Roberts. I'm a research associate here under Corolla, and then I'll be speaking in my capacity at the university for this talk. So what's our motivation? So as a background, I'll be talking about the COVID collaboration that we've been running out of the maths department so far for creating machine learning models for helping with clinical data and imaging data. And so the motivation behind it is in China, in the early days of the pandemic, they were identifying features in the CT imaging that were used to diagnose COVID, or to at least triage the patients in the hospitals. And as well as identifying chest X-ray features, this gave a lot of motivation to us to think that, and a moral obligation to think we could use our imaging and data science and machine learning skills to try and extract those features from the images and predict outcomes for COVID patients. So for COVID, you have this whole zoo of healthcare data. So in addition to the chest X-ray and CT imaging, we've got the health record data, which in Cambridge is very, very granular. We have blood data, PCR results, and the interventions that were performed on the patients. And the question really is, can we use image analysis, data analysis, and machine learning techniques to extract the signals within those data for prognosis and diagnosis? And can we combine the multiple different streams of data and, to get a more accurate prediction of what will happen to the patients? And then our key aim with this project is also to implement it within the clinic. So this is kind of a slide just showing the scale of the collaboration at the moment. So we have a wide breadth of skill sets behind us. So back in March, we formed a kind of initial investigator group, and then we've kind of ballooned over the last year to include people from math, statistics, image science, data science, machine learning, a lot of clinicians as well, and a lot of hospitals, as well as a lot of SMEs coming in who are providing support. So this kind of just shows the timeline of the project. So back in March of last year, we assembled our key group, and we decided to join an EU-wide project called Dragon. And Dragon was initially for identifying radiomic signatures in images that could be used for pandemic preparedness in future. And so we actually got, the Dragon project got funded in May of last year as well. But in the meantime, we got our first data from China. So the irony was, because China was hit so hard, so fast, by April, they had the time and the ability to extract the images and actually send them over to the UK. So whilst we didn't have UK imaging or European imaging, we had a lot of China data, which was mainly CT. And in the meantime, we also started a literature review, which I'll talk about later, that then ballooned into a systematic review. Over the summer of that year, we also got approval for a national UK data set called the NCCID from NHSX and the STI, and we got our ethics granted through Cambridge, through Addenbrooke's, Chelsea, Westminster, and Vienna. So it did take 4 months to get approval for the imaging from Cambridge, but we got there in the end. And we also in that time recruited 4 postdocs into the algorithm team, but also the clinical team. And then towards the end of the year, our systematic review of the literature was accepted. We brought in more global collaborators from US and Brazil, and the postdocs started. And then earlier this year, we started to detect there were potentially signals within the blood data that we had that could indicate that there was a pandemic in action retrospectively. And our systematic review and the opinion pieces were finally published. And then this month we're last month now, participating in an NHSX COVID-19 validation exercise. So testing one of our algorithms to see how does it validate on a holdout set that they've had. And through this whole time, we've been expanding the collaboration, bringing in partners throughout the world. We've had calls every day between the clinical and algorithm groups to ensure that we're really all singing from the same hymn sheet, and we are identifying the right clinical questions to be asking, because the situation evolves so dynamically. Like 6 months ago, we weren't talking at all about strains, and now they form quite a big part of the conversation. So back at the start in April, Julia Gog published this article that said that a lot of people were going to feel an obligation to use their skills to help in some way to tackle the COVID pandemic. But rather than add to the noise, you should really aim to amplify the signal. And this is a real motivator for us, that we want to only contribute positively to the literature and positively to the models that are out there. So following this advice, we started with a systematic review of the literature. And so we considered any papers that use machine learning along with chest X-ray and CT imaging for COVID-19 diagnosis or prognosis. So there were 320 papers that fell eligible for our review. And that's a kind of Herculean task to review that many papers. And once, so we decided it was wise to put in a quality review step. And so we did basic quality screening to exclude the poorest quality manuscripts. So any that didn't document, for example, their data set that they were using. They didn't document how they assigned the data to the train, validation, and holdout sets, didn't document their pre-processing, and didn't document how they selected their final model. And that's all detailed in the paper. But we chose very liberal criteria to just really focus on the higher quality of the papers. And this left us with 62 papers. And then in the paper, we conclude that none of them are of safe clinical utility due to lots of issues. And we also make lots of recommendations. I'll just focus on some of the highlights of the pitfalls that we found. So one of them that we really had issue with was there were lots of issues around data sourcing. So it's very unclear, because data was produced in such a rush, where the original sources of data and the labels were. And so we can see here there's quite a complex organogram of data sets, and that you can see the genealogy of some. So for example, if we take the CERM data set, that was a publicly available data set, it then merged into 2 other data sets, which then all merged into another data set. And so this COVID-X data set inadvertently includes 3 copies of all the images from the CERM data set. And so these images fall into the train, validation, and test sets of some people, and we end up with lots of very optimistic models, which may have been developed with the best of intentions, but they had no idea of the genealogy of these data sets. And it's only by taking a kind of careful, considered approach that you can develop these. Another thing is the underlying biases in your data. So lots of models used like pediatric patients' chest X-rays that had pneumonia as their control set, and then would use adult COVID patients as their positive COVID set. And so the way that they X-ray babies is very, very different to the way that they X-ray an adult, and the deep learning algorithm is very, very fast at picking that up. And so you kind of design this very, very sophisticated adult v child detector rather than a COVID v non-COVID detector. And this happened in a lot of the papers. And also there are biases in how the images are labeled. So in chest X-ray, it's very, very common to have labels put on the image. But it's quite obvious that if a patient's standing up as opposed to lying down, the patient that's standing up is probably a little bit healthier than the patient lying down. And that's recorded in the image. And we can see here that there's some attention maps where we see the network is paying attention to the label on the image as well. And so that's a massive bias for a prognosis model. Also, the ground truth being assigned based on the images themselves. So lots of people came out with radiologists who looked at the chest X-rays and then labeled them as COVID positive and negative. But this really hard codes into your algorithm any of the biases that the radiologist has. It's much, much better to use a PCR, an antibody test, or any other test than labeling based on the image. And finally, the resolution of these images was driven by the networks themselves. So a chest X-ray is normally thousands of pixels by thousands of pixels, but it was very common to see them downsampled to 224 or 320 square. And that's due to the nature of the pre-trained networks for chest X-rays. And so, but the resolution that you train on and the resolution that you evaluate your algorithm on should be driven by a clinical decision rather than the need to satisfy already existing algorithms. So our key recommendations were to make it reproducible. So from the manuscripts themselves, the documentation needed to be sufficient to allow someone with the skills to reproduce that model, and then code release and also releasing the model. Like, the pandemic couldn't have been a worse time for people holding back models and holding back their code, because we needed models out there and we needed things that we could validate, and they just weren't available. Also, for the standards of development are more like kind of the Wild West out there. So there wasn't a consistent approach to developing models and a consistent approach to evaluating the performance. So we encourage people to use some established checklists that have been made over the past few years to really hold your paper to these standards and check that you satisfy the criteria. And then also calibration. So this is almost never considered really in the literature, was what is your model output? If you're predicting the probability that someone will die at 90% versus 60%, is that meaningful? Because that will change the clinical decision. So if you're just thresholding your values and you get a great discrimination statistic, it masks the calibration underlying that. So we'd encourage people to really consider calibration. And then also working collaboratively across the disciplines. So many issues that we identified were only found because we were working with clinicians. And it was crucial in our decision-making process about which approaches we would take when we got to kind of forks in the road. And it's also crucial to work with across disciplines to really understand what are the clinical requirements of the tool you're developing. Like, what, for a radiologist, they don't want any extra clicks on their machine. They just want it to integrate seamlessly. And so really understanding how would you like to interact with this and what interface would you like? And then we can work on the other side of that. And also really important to have them for those dynamic shifts in the discussions. So as new strains emerge, how does that change the questions that we're asking? Okay. So just a bit about the collaboration itself. So I spent a lot of time developing kind of a high quality network of hospitals around the world that we could get good quality data sets from, where they were well structured. We knew exactly where the labels had come from. We had lots and lots of detailed clinical information. And I think this is really important to have these global data sets, because we don't want a model that just works in one country. We want to make sure that we can see if it validates in another country, or we can develop models that are locally trained for that population. And so this is kind of just a highlight of the 6 key themes of the collaboration. So we're studying the CT and chest X-ray imaging. We've got monitoring of the longitudinal clinical data. Away from the lung parenchyma, we're also considering, because cardiovascular health is so important for outcomes, considering calcium scoring and also heart segmentations of these patients. Really studying the full blood count to see if the structures of the blood cells change in COVID patients, if they affect outcomes in COVID patients. Don't yet know, but it'd be very, very nice to find out a simple marker, because these tests are so cheap. And then a quality control step. So I've got a little bit about each that I can talk through if we've got time. So in the CT analysis, we've segmented all the CT scans that we have into ground glass and consolidation regions. And then we can consider, are there features of each of the regions or features of the distribution of these regions that affect the outcome for these patients, and create a biologically meaningful predictor. For chest X-ray as well, segmenting out the lung parenchyma, really enhancing the images, studying the features of the chest X-ray and linking to outcome. And then just for full blood count, it's the most common clinical test globally, with 3.6 billion per year, and is already used to come up with a likely diagnosis of a viral or bacterial infection for patients when they turn up at hospital. It's cheap, routine, and scalable. So back in April and May, really, the testing was so poor in the UK. We need something that can scale next time a pandemic hits, that we can do a really rapid test. And these machines sit in every hospital and a lot of GP surgeries around the world. So if we can detect, is there a viral signature in the blood? Is there a COVID-19 specific signature in the blood? And then is there a prognostic signature in the blood? this would give you a very fast test for COVID, but also give a likely prognosis for those patients. And the last thing I'm just going to talk about was quality control. So we have within one data set, for example, these are 6 different types of images we can get. So the top left is a perfect chest x-ray that we'd like. We then get lateral images, inverted images, over and under exposed images, scratched images, and images with pacemakers on. And a lot of the COVID patients, around 10% of the ones in our data set, have pacemakers. And it's not going to be particularly surprising that if you've got a pacemaker, you probably have a poorer outcome than someone without one. So we want to know and really understand the biases that exist in our imaging data. So we're developing a tool for automated triage of chest x-rays. One thing, it's practical to know what biases exist in the data set, but also to understand, can we, if we got a data load of 20,000 chest x-rays, how can we quickly triage them into, these are the good quality images that we should use to develop the models, and these ones need further review, and these ones should be rejected straight away. And that's everything.
Thanks a lot, Mike. Thank you very much. Other questions? I think there is a Q&A. Okay, so I'll read the question, Mike, yeah? I will not try to unmute someone again because I don't know how to do it, although it would be nice. Okay, so the question comes from Paul Metcalf. And the question is, how much of your systematic review was a surprise? What you've listed is pretty much the standard list of ways to shoot yourself in the foot for machine learning in healthcare, or indeed machine learning in practice.
I suppose it was, some of it wasn't a massive surprise. There were just a lot of things that were unique to COVID. And I think with like the fast release of data sets to lead to these massive Frankenstein data sets that were kind of compiled all over the place. There were so many data sets out there, and it really took sitting down and drawing out the genealogy of every single one to figure out what was going on there. What else was COVID specific? I suppose this pneumonia data set as well. It was never explained in a lot of papers that they were pediatric patients. And so that came as a real surprise that we really found that was the case. But I'm trying to think what else would be a surprise in there. But I think I expected a lot of poor development, but I didn't expect it on the scale that it existed. It was really quite shocking that there was a lot of human energy and time had gone into writing 320 papers, and that there was not that much of utility in there.
I think especially because all of these attempts in a way were really sort of helping within the pandemic, right? So helping management of COVID patients. And that's, that's what all of us wanted to do with this. But it was a little bit, sobering, let's say. To see that it was really, it seemed very, very difficult to do this for many people, and for various reasons.
I think we hoped that we would be able to piggyback on, if there is an existing approach and an existing model that was developed really nicely, that we could be able to use that as an initialization, and we could apply it to our own data and really see if they validate. But the ways they were developed just meant that we really couldn't consider taking any of them forward, unfortunately.
Yeah, I think, to be fair to everyone that has been featured also in the systematic review, and I don't know, Mike, if you want to add something to that, but I think one main component that we also faced was just data availability and how long it took to actually access the data from various places. And so, necessarily people were trying to get data in any way that was possible. And I think some of these Frankenstein data sets, for instance, just came out of this kind of need.
Yeah, absolutely. Yeah, I think it's a good lesson for the future of we should change the way we can get access quickly to clinical data and clinical imaging, especially. I think the raw EHR data we could have got far faster than joining it with a request for imaging, and extracting images from hospitals is known to be an issue, but now we know it's an issue. We really need to do something about it and make it far, far faster next time a pandemic hits.
Yeah. Good. So in the interest of time, I think we should have at least 8 minutes of a break. Thanks a lot to all the speakers for really fascinating talks. I really look forward to all the things that are coming out of all the hubs that have started recently, and look forward to working more on the COVID project with you, Mike. So let's have a break for 8 minutes now.